Okay, thank you, of course, for the invitation. As been said, I'm a radiation oncologist at Ghent. One of my main topics is prostate cancer and oligometastasis. And a couple of years ago, actually 3 years ago, somebody asked me to take over melanoma and radiotherapy as well, because that was one of the topics that nobody wanted because there were almost no indications for radiotherapy, or that's what has been said. And when I started taking that one over, I run into checkpoint inhibitors and started to get involved in radiotherapy and combinations. That's probably why I'm here now. An overview of my talk, I'm going to cover just a general introduction, talk about what everybody's always discussing, this abscopal effect, something about the radiotherapy dose, fractionation schedules, timing, what about toxicity, and of course the first early clinical results that are published recently and the ones that you could be expecting. We all know this is an example of renal cell. This is a review we did for renal cell and whether or not radiotherapy might be interesting in that field. We all know that renal cell has a very anti-immunogenic tumor environment and the tumor itself as well, and that the balance, of course, is not pro-immunogenic. A lot of preclinical data suggests that radiation somehow, I will come back to that later, might actually change that balance in favor of a pro-immunogenic environment, so that radiotherapy can actually alter this environment or actually change it in the benefit of outcome. That's what we came up following that review, and that's what others suggested as well. There are many, I think there are more reviews on combination therapies than there are actually clinical results or even patients. I think there are more reviewed than actual patients treated. Nevertheless, this shows this is a very hot topic. For me, this is an interesting one. This is just one of the reviews, but I think it's quite comprehensive. It's from Bernstein 2 years ago, showing that they said, well, if you go for stereotactic body radiotherapy, I will come back also to that, whether or not that is necessary, and you give radiation to a primary tumor, we all know it gives cell death and necrosis, but we also target the microenvironment. It's not only the tumor that we're able to irradiate, we do more damage than that. And if you just follow the different pathways, you can see that there is not only cell death and necrosis, but there are also the so-called DAMPs, and there are antigens that are created. These antigens can be picked up by our immune system, the dendritic cells, and they can give us the T cells that we need. Same things can happen in the tumor microenvironment. And if you combine that with whatever molecule you have there, you can actually have a synergy where you can have an effect on your tumor, but also, because you have these T cells, on distant tumor cells, not only locally, but also distant. And this is just an example or an overview of showing what the different action points could be. Most of this is based on preclinical data, and that's important for you to realize. I think there are more than 3 players, but 3 important players that we can actually regulate with radiotherapy. You've got, of course, the cancer cell. You can create cell death, antigen release with radiotherapy. You can have costimulatory molecules that you release. You have an influence on your dendritic cells. Radiation therapy has been shown to increase its maturation, improve cross-presentation. And for your T cells, you get an increased infiltration, and you can have a maintenance of their effector function. So all things that appear to be positive with radiotherapy. Another overview of this immunogenic cell death, because that is what we are targeting or aiming for, but just to show you that with radiotherapy we're also inducing non-immunogenic cell death. But this is what we are aiming for if we go for combinations. This is what we actually want if we want a distant effect, not only locally, but a distant effect, again, with the influence of the dendritic cells. The question now, of course, is how do we get a combination of both, or how can we actually make sure that if we irradiate and we want a pro-immunogenic response, how do we get this without this, or the balance more into the right-hand side? That's something that we actually do not know or fully comprehend. So radiotherapy looking at the preclinical data, it's clear that there is a systemic effect. We have cytokine release, we have antigen release. There is an effect on our immune cell. Just think of local therapies that we sometimes use. For example, if you have an antalgic radiotherapy for pain, we know that we influence the white blood cells. We know we influence cytokines. So just showing that there are a lot of systemic effects. But the thing is, how can we orchestrate everything that it works in our favor? So the abscopal effect is a slide that I got from the Maria. If you got two tumor sites and one of them you irradiate, and you see not only this one, the one irradiated shrinking, but you also see the other one that you didn't influence radiotherapy. You see that one as well that starts to shrink. Then you have a so-called abscopal effect. And there's one famous example which I will show you, but you all know probably. So this was one of the first very interesting, very comprehensive as well experiments showing that when you have mouse with two tumors induced and you irradiate one of them in combination with an dendritic cell stimulating agent, so if you add that local radiotherapy to one of the two tumors, what would happen? That's what the Maria and the group looked into. So they did different experiments, some with sham control. So of course the mice that were left untreated, you see here the tumor weight or the tumor load. You see that this is the primary tumor irradiated, the one that is not irradiated, this is the sham control. So of course you just see an increase, and this is the non-irradiated, you also see a clear increase. Now, however, if you look at the dendritic cell stimulation, you just see increase. No tumor reduction, not at the primary site, not at the non-irradiated site. So apparently dendritic cell vaccination or this type did not work. If you add radiotherapy, okay, clearly the cells that you irradiate, they decrease, no doubt, but no abscopal effect. So radiotherapy as such, in this experimental setup, did not show any abscopal effect. However, this is the more important arm. When you combine dendritic cell stimulation in combination with radiotherapy, not only the irradiated tumor reduced, but also the other one. And this is a very interesting proof of concept showing that in these very nicely controlled preclinical data that you're able to show that this abscopal effect, that it does exist. So radiotherapy alone probably will not be good enough. We'll probably need something in addition to it. And that's why when we do radiotherapy every day, and it's quite rarely that we observe these abscopal effects. For example, if we irradiate for palliative reasons, we give a high dose or a certain dose to a certain region. It's very rare that without giving any other treatment that we will see distant responses, or there are case reports. So it might be that based on these experiments, it was postulated that radiotherapy might have a new role to play in combination with drugs that can somehow inflict the immune system, that are immunomodulatory. Just to show you, this is an overview of all the potential targets there are. There are many. And all of them you could think of, why not combine these with radiotherapy? Or why not take several of them together and combine those with radiotherapy? This is one from, I think, 2 or 3 years ago. And if you would update this one, there are even more molecules that you could potentially think of combining. So again, there are so many options out there. Which one are the ones that we should look at for radiotherapy combination? Looking into what type of radiotherapy. There are different ways how to deliver it. You can fractionate, so giving a certain dose every day, or you could say, okay, I'll deliver all my dose in one fraction. Is there any evidence out there what we should be doing? Actually, there are nice experiments. There are also smaller experiments that contradict these data, but nevertheless, most of the evidence preclinically is in favor of fractionation. If you look at the type of inflammation induced by standard fractionation, so normally we give 2 gray or 1.8 gray a day for several weeks. Then you get a chronic inflammation. That's not what we want. We actually want acute inflammation. We want peaks of acute inflammation with what they call radiation holidays in between. So this acute inflammation stimulates immunity, while this chronic inflammation is not what we want. So probably these more fractionated high-dose radiotherapy, this SBRT, which we often apply, might be the more interesting one to investigate. So if you would consider a trial, probably I would do it with this, not with that one. Of course, this is based on an experiment, and this is this is done in 2009, so quite old as well, but nevertheless very interesting. Different fractionation schedules investigated. Again, you have your primary tumor, you have your secondary tumor. One of them is irradiated, and again, they give an antibody to stimulate the immune system. And here as well, if you look at the single fraction or the 3 times 8 on the local control, so the one that you irradiate, doesn't make a difference. We know that very high doses in a single fraction are very good for tumor control. Very excellent. So if you want to irradiate locally and you just want to see this local effect, please go for a single fraction without a doubt. No issue with that. However, if you want to elicit an abscopal effect, there it is different. Here, this is the 3 times 8, so the fractionated one, and this is the single fraction. Again, the tumor volume, if you go lower on the body, the lower is better. So here, the non-irradiated side, you see a clear abscopal effect with this schedule, and you're not seeing it with that schedule. So again, showing that probably this is the best way to go. And also this one in between, this other schedule was also appeared to be less good. So that's why a lot of trials, a lot of clinical trials now running, typically use this dose, 8 grade 3 fractions. That's what we typically use as well. So based on this, we decided to fractionate. There are a lot of other smaller studies that are, well, in my opinion, less elegantly done, that try to convince you otherwise. But nevertheless, we opted for this schedule. One of my friends in Australia from Melbourne, actually, they went the other way around. They said, we will do the other thing. You go for 3 times 8 perfectly. You do your studies. We'll take one single fraction of 20 gray. And that's what they do. They're doing the trials with single fraction. We're doing the fractionation. What about timing? You know that when your oncologist asks you, okay, we will start with, for example, pembrolizumab. Can you irradiate this or this lesion because that is painful? Of course you can do it. Then one of the questions they will ask you, okay, do I have to interrupt my treatment? That's a question we got a lot. Or how do I have to time it in accordance to your radiotherapy? Well, this is again this is looking at the optimization of this timing. Experimental design, again, very easy. You give an immune system stimulator, you give your ipilimumab and radiotherapy 14 days later. Same thing here, but the timing is different, and again the same here, but the timing is different. So by timing radiotherapy on different days, or the ipilimumab at different days, so here you see that radiotherapy is given before, radiotherapy is given before. So different timings, different sequencing of your radiotherapy and your drug. And it appears that in this magical combination was actually this one, the first one. So you first give your ipilimumab, and then you give your radiotherapy, and not the other way around. Again, interesting. So ipilimumab was most effective when given prior to radiotherapy. And it might be that because your ipilimumab regulates your T-cell division. They continued, and they looked at another drug, OX40. That's one of the drugs that we also have in our phase 1 trials running with different combinations. And they did the same experiment, but with just the other drug. Now here it appeared that this combination, well, it is not as good as ipilimumab, but this combination with OX40 was the most interesting one. So not the same sequence as ipilimumab, but different sequence. Now, what if you want to combine ipi with anti-OX40? How are you then going to combine this? I have no idea. They didn't do that experiment. But you have to think, what is the drug doing? And what is my radiotherapy doing? So how am I going to optimally address this timing?
This is in local results, not abscopal.
These were local results. Again, looking at the timing, this is another interesting experiment they did. So looking at the different, this is with anti-PD-L1, antibodies starting on different days, day 1 of radiotherapy, day 5 of radiotherapy, 7 days after the last dose of radiotherapy. So A, B, C, again with implantation at first and then giving the drug. And here it appears that these schedules were the most interesting ones. So schedule A, B being this one, antibodies starting on day 1. So there you start with your radiotherapy and, for example, Nivo, Pembro on the same day. So a different sequence than with your ipilimumab, different sequence than with your anti-OX40. So again, showing that depending on the drug, your timing is very, very important. So timing of radiotherapy is determined by the molecule used. So again, if you're designing a trial, a certain trial, you have to think beforehand, okay, how are we going to sequence this? Because otherwise you might end up with a negative trial just because of you got the concept wrong. This is the very famous, very famous case that started it all. Everybody probably read that one. That's from the New England Journal of Medicine. There was a patient that was progressive while under immunotherapy, and there was a painful localization, and that painful localization was irradiated. The drug was continued, which was allowed, and they didn't only, because the patient was progressive under the drug, they didn't stop it, they just added the radiotherapy, and all of a sudden they saw disappearance of the spleen metastasis, for example, the mediastinal nodes, and they saw shrinking of the liver met. So this was one of the cases that sparked the enthusiasm of a lot of people. So that patient was progressing, antalgic radiotherapy, so actually the dose was not extremely high, and they saw regression of the irradiated lesion, but also they saw this abscopal effect, and they also were able to show in the blood of this patient, they saw interesting, maybe I'm not supposed to call it immunomonitoring, but nevertheless they saw a decline in certain thresholds. So this is the one that sparked everything, and that's why we're probably now doing the different trials. Also a very nice case, it was a very large neck mass of a melanoma, again treated with the drugs as we all do, but then that patient, as you can see, it was an enormous mass. It was actually treated with grid therapy. Grid therapy is probably something that we normally in clinical routine do not do. We experimented with it a couple of years ago I think it was in 2008 that we also tried this. But nevertheless, what it does is you take a big seroband block, you drill holes in it, and you got like a big cheese with holes in it, and you just irradiate through that. So you create actually a grid of radiotherapy, and if you look at coronally, you see that high doses with no doses in between. So this is the concept of not irradiating the whole tumor. That's also often we get questions, should we irradiate the whole mass? Maybe not. Maybe not. So what they did here, they gave a single fraction of 20 gray followed by conventional fractionation. So they did a single fraction followed by normal fractionation. If I would have done this, I would probably use a different dose, but nevertheless, this is the result. This is quite spectacular. In my opinion, even with the doses that they used, having a cosmetic result of a patient that is that progressive, this seems to me a very impressive local result. So it might be that in certain situations where we want to obtain a good local control, for example, like in lung cancer, that chemoradiation, maybe in some years we will not be doing that. It will be one of the drugs plus radiation. So because of this excellent local control, and maybe we can lower our radiotherapy dose as well. A lot of things that we could investigate. This again from the group of De Maria and Formenti. A very interesting trial that took a long time to recruit, but nevertheless, it is actually a proof of principle. So they had patients with different malignancies that were actually progressive and didn't have any options anymore. So what they decided, that they wanted to add GM-CSF. Now GM-CSF normally does not give you any nice responses anymore of patients that really have no treatment anymore. But nevertheless, what they saw that 27% of patients with metastatic solid tumors experienced an abscopal response. So they irradiated in combination with this GM-CSF, where normally you would not expect anything. 1 out of 4 had a nice response. And this is the waterfall plot of the best abscopal responses, showing that indeed there is some signal in here. Where normally you would, if you would only give GM-CSF in these patients, maybe you would get 5%. But here they got 27%, which is nice. But of course, if you look at the number of bars, the total number of patients was small. Proof of principle, again, showing that radiotherapy might help us in getting us to the necessary systemic effects that we want. This is a phase 1 trial with a lot of preclinical data generated in there. This is a very nice publication of Twyman Saint-Victor. And what they did, they gave ipilimumab, and they gave radiotherapy before to the index lesion, what they define as index lesion, and they gave typically 8 gray times 2, 8 gray times 3, or another dose, 6 gray per fraction. So hypofractionation, no single fractions. The median progression-free survival was 3.8 months, which in my opinion is not that different from EP only. So if you look at the waterfall plot, the results were not that amazing. So they looked into it. Why is this? That this combination is not ideal. I will come back to toxicity later. In their mice experiment, they saw that resistance was due to upregulation of PD-L1 on melanoma cells and associated with T-cell exhaustion. And they said, well, these high PD-L1 patients, they do not respond to radiotherapy plus anti-CTLA-4, demonstrate persistent T-cell exhaustion and rapidly progress. So they concluded in their, and they did that in the mice experience as well, that PD-L1 on melanoma cells allows tumors to escape EP, and probably here we need a combination of and radiotherapy and EP and pembrolizumab or nivo. And this is now what the group of Formenti de Maria is also doing in a randomized trial. So they're randomizing patients to the classical combo in melanoma, and they randomize no radiation versus radiation. So something to look forward to. What about, this is no prospective data, this is retrospective data. This is Keynote 001, just looking at previous radiotherapy and the clinical activity and toxicity of pembro in the treatment of non-small cell lung. Here you see that this is the radiotherapy, no radiotherapy. Again, they show that patients that previously received radiotherapy did better. Of course, enormous selection bias in here. Nevertheless, it made Lancet Oncology somehow. But this just shows you how popular this topic is if these type of retrospective analysis can get in there. But shows again a positive thing. Maybe a missed opportunity in prostate cancer. This is also a very famous trial where they tried IPI versus placebo after radiotherapy. So again, first radiotherapy and then IPI, probably not the best thing to do, we know now. But nevertheless, I think they randomized 700 to 800 patients. And we know that prostate cancer is not a very immunogenic tumor, and the p-value was 0.053. So this was considered a negative trial. They said, well, this combination is not of interest. Well, actually, they decided IPI is not of interest. However, if you look at patients with adverse prognostic factors, there was a difference. And there was a nice overall survival difference with a hazard ratio of 0.62, which is not that bad. So a lot of us were hoping that they would still do a trial specifically in these patients and that they would get their radiotherapy differently, more go for fractionated radiotherapy, not for single fraction, and get that timing differently, but they did not follow through. I discussed a bit with Eugene He's in the Mayo Clinic, very nice guy, and he said, well, they probably want to invest first in other markets, which there is more opportunities financially, maybe, or more opportunities of seeing an effect, and maybe not in this field. But there are still drugs being investigated in prostate cancer as well. But maybe a bit of a missed opportunity, as this was phase 1. So the dose, probably wrong, 1 times A grade. It was bone that was targeted. Maybe bone is not ideal, we don't know. And the timing was wrong, or potentially wrong. Now, what about toxicity? A question we got asked a lot, and then this is one of the systematic reviews that has been done looking at cranial stereotactic radiotherapy and extracranial stereotactic radiotherapy. The size of the dots is actually the size of the number of patients included, and here you got the different drugs aligned. So if you want to look at whether or not, for example, ipilimumab and radiotherapy to the brain, is that an issue? Well, if you accept 10% grade 3 toxicity, it is not an issue. However, here if you look, for example, with any of the new anti-PD-1, anti-PD-L1 drugs, no data yet at time of that publication. Now we've got some data. So if you want to know about the safety of radiotherapy with pembrolizumab concomitantly, I don't know. But there are certain drugs that probably should not be combined with radiotherapy. But this gives you some overview or something to refer to. But there are more data necessary, especially with the newer drugs, to look into the safety of this combination. So they said, well, cranial radiotherapy well tolerated when combined with the majority of targeted drugs, but look out with certain combination. Same with extracranial radiotherapy, go ahead, but look out when combined with these drugs. Something to consider in your clinical practice. If you see 30% grade 3 toxicity, that's a lot, and I would not go for it in those combinations. Now, if you look at the kinetics of toxicity, that might also be of relevance. Maybe you will see different toxicities if you give it during different time points if you give your radiotherapy during different time points. Maybe you will see more liver toxicity if you radiate a liver lesion more at 6 to 8 weeks after or during that drug that you're giving. So maybe that is also something we should be warranted about, that it might be that because there are the different time points of toxicity, you might see different toxicity in your patient, or you might see more toxicity than you were expecting. So choosing the right timing is very, very important, not only to see an optimal effect on the tumor locally, but also distant, and it might also be relevant for the toxicity that you're seeing. So again, looking at toxicity now of the Keynote trial, well, actually they did see, so patients that did not receive previous thoracic radiotherapy or did, there was a 23% difference in any pulmonary toxicity. And treatment-related pulmonary toxicity here again, although small, there was a difference. So it might be that these combinations are not that safe, so I think they should still be investigated in prospective phase 1, phase 2 trials before we just do that in clinical routine. There's also that Pacific study where chemoradiotherapy was given to lung cancer patients, then followed with durvalumab. And what they saw is, well, there was a nice advantage of the drug as compared to placebo, but they also, what is more important, they looked at pneumonitis risk, and there was also a difference noted. So although there is a benefit of giving chemoradiotherapy followed by the drug, we are seeing more toxicity in the combination. So some say, well, might be that radiotherapy given previously still impacts future toxicity. So something to also be warranted about it. If your patient received previous radiotherapy, it might be that you see a delayed toxicity there. This was just a recent publication. Again, this is just as a warning. They irradiated 6 cases I think it was with anti-PD-1 inhibitors, where they here, in this case, they irradiated a spleen metastasis. They saw a very nasty pneumonitis. Here as well, they irradiated, this was a colorectal patient, I believe. They irradiated a lung met, and again, they saw pneumonitis. Just, this is 2 out of 6 patients, so quite a lot of toxicity. That's why they reported this. Again, as a warning, don't do this because you think you will have an abscopal effect. Be afraid of toxicities that you do not want to see. Normally, if you give a high dose SBRT, you expect around 10-11% of grade 3 pneumonitis. When you give drugs only like pembrolizumab, you expect far lower. If you combine them and you have 1 out of 3, that might be a problem. Fine.
In these cases, toxicity or inflammation was only seen within the field of radiation.
Yeah.
It didn't behave like an
Interstitial.
induced
No.
diffuse interstitial.
No.
It's like your
It was in that field. The thing was, they didn't publish the fields, so we cannot know for sure. But here, this lung seemed normal, and if you would irradiate this one, I think that was done with a classical IMRT. Some do VMATs, but nevertheless, I think that the dose on the contralateral lung should be very low. So here as well, you see the same. The other lung appear to be well. So just as a warning that maybe we should do first phase 1 trials, phase 2 trials, before we just start combining, before we see things that we do not want to see. And the only thing to know for sure is doing it in a trial and reporting it. If everybody does it in his own center and doesn't report it, nobody knows. And then 100 centers all over the world start treating these patients and not reporting their toxicity, then we are damaging too many patients. That's my opinion. This is the different phase 1 trials. This is our study that we did. They didn't report the actual grade, but nevertheless, if you look at the toxicity, for example, here very high, but do mind that the ipilimumab dose was far higher. We saw in our trial 1 out of 4 grade 3 to 4 toxicity. We did radiotherapy before 3rd cycle of IP, so according to preclinical trials, that should be good. We gave the dose that is now used, and you can see that different total doses are used, different fractionations are used, different dosage of IPI is used, and different timings are used. For us, it was very difficult to see whether or not there is a certain toxicity effect. However, what we did note is when we looked at our overall response rate, we got the lowest overall response rate of all studies. But however, what we did is we used the highest radiotherapy dose. There were 2 patients in our dose escalated radiotherapy. So 2 were treated at 3 times 8, 1 at 3 times 10, and the other ones all got 36 and 3 fractions, so a higher dose. And there's now preclinical data that if you give a radiotherapy dose that is too high, that you will not see an immune response. So probably the sweet spot is giving a dose which is, if you give radiotherapy alone, sublethal, so 3 times 8, and that might be the ideal one. So probably dose escalation in combination with the drugs to get an immune response might not be ideal. Of course, 13 patients. So these are the things that we did the past years. We did one with pazopanib and SBRT. That one is published. We did this one in IPI, is published. We're now doing combination with concurrent PD-1 blockade and melanoma, phase 2 trial, almost finished. And we finished a randomized phase 1 trial where we randomized the timing of radiotherapy in bladder. So we radiotherapy first, then pembrolizumab, or pembrolizumab and radiotherapy before the 3rd cycle, to look at is there a difference in toxicity. And that one will be on Astro for those interested. So for me, the key messages are radiotherapy has systemic effects. Some we like, some we don't like. And it will be up to us to design the trials or design the combinations that we get it right. Because if we get it wrong, we will see more toxicity and less effect. So I think we can actually get it wrong, so it's important to do smart trials. Probably fractionate, ideal I don't know, but 3 times 8 gray seems the one that keeps on popping up in several preclinical data. Also, get your timing right, but what is ideal for tumor control and the balance with toxicity, we don't know. Early clinical results are promising, but the majority of them are actually non-randomized, so still a lot to be discussed. These are some of the trials that are running. So as you can see, a lot of different drugs, a lot of different doses, a lot of different targets. Some do concurrent, some do different. And this was in 2016. If you would update this now, you get probably more than 100 trials running to look at combinations. So a lot of them are happening. We are going to start a CHEERS trial. So if you guys would be interested in joining, we're very open to whoever wants to participate. This will be checkpoint inhibitors during 4 cycles, then followed by immunoboost by external radiotherapy in solid tumors. What we will do is we will include non-small cell melanoma, TCCs, RCCs, head and neck, so all the reimbursed ones, so the ones that are reimbursed. We're not going to include non-small cell first line because the pneumologists didn't want to, but we are getting the second lines. Nevertheless, drugs are reimbursed. What we are going to do, they will get their 4 cycles, then we will randomize to standard of care. It might be that they continue immunotherapy, it might be that they switch to something else if they are progressive, we don't care. They will be randomized to SBRT to maximum of 3 lesions. If there's 1 lesion, we'll do 1. If there are 10 lesions, we will pick 3 out of 10. The ones that are most progressive, we will choose, and they also will get standard of care, being whatever drugs is used can be continued, whatever is the standard of care can be continued, and patients will be followed up. Primary endpoint will be progression-free survival. With, if you take all these together, the median PFS is between 2 to 4 months, so on average is 3. We hope to get a PFS of 6 months, which is of course maybe a bit too optimistic, but nevertheless, we're going to try to make this work. So total number of patients that will be randomized will be 76, and we will be submitting this to Stichting Tegenkanker, for example. So already been submitted to Comop Tegenkanker as well. So if anyone interested, this is a trial that any hospital can join. It might be interesting. Maybe you have different trials running for some of these, but in others you don't have anything running, then you shouldn't be enrolling all these different sites. But if you, for example, have nothing going on in RCC second line and you're just giving nivo whatever, they can actually go in this trial. So I'm happy to take any questions. Of course, this is not me alone. This is on behalf of a lot of people collaborating